I welcome him to speak today's topic, statin intolerance. Sir, welcome, sir.
Next 15 minutes, I'll be talking on statin intolerance. Statin intolerance is in focus again because of monopoly of reasons. Firstly, we have the NLA statement this year in June 2022. Secondly, we have the Lipid Association of India statement in August 2022, which I'll be showing. And Bempedoic acid has emerged as a boon to patients of statin intolerance. And lastly, a combination of pitavastatin, ezetimibe, and Bempedoic acid has emerged as affordable and a very effective combination for treating statin intolerance. So why are we so much concerned about statin intolerance? The reason is, if there is statin intolerance, this results in discontinuation of therapy, which increases the risk of adverse cardiovascular outcomes. Here you can see in this study, the cumulative incidence of recurrent MI, CHD events, and all-cause mortality in statin intolerance was compared to high adherence to high-intensity statin patients. And you can see there is a 36% higher rate of recurrent MI with a hazard ratio of 1.50 in statin intolerance. And the recurrence myocardial infarction, there's a 46% higher rate of coronary heart events. Hazard ratio is 1.51. This is another data from the Korea. And again, you can see if you are a statin intolerance, there is a threefold increase in the all-cause mortality and a fourfold increase in the cardiac mortality. A panoply of professional bodies have issued statements on statin intolerance, as you can see on the slide, but I'll be talking only about the current NLA statement 2022. Statin intolerance is defined as one or more adverse effects associated with statin therapy, which resolves or improves with load reduction or discontinuation. Statin intolerance could be complete or partial. Complete statin intolerance implies that the patient is not able to tolerate any dose of a statin and the incidence is less than 5%. Whereas partial statin intolerance implies that the patient is unable to tolerate the dose of statin necessary to achieve the patient-specific therapeutic objective. For diagnosing statin intolerance, a minimum of 2 statins should be attempted, including at least one of the lowest approved daily dose. What is the prevalence of statin-associated muscle symptoms? RCD, obviously, the incidence is much less than 5%. But in clinical practice, the prevalence is to the tune of 10 to 15%, and NLA, it was 5 to 30%. So what are the adverse effects of statins? The muscles bear the brunt of statin intolerance, and myalgias are the most common symptom, but they are seen only in 1.5 to 3% of patients. They manifest as muscle aches, pains, cramps, fatigue or weakness, and there may also be a nocebo effect. Myopathy occurs in 1 out of 10,000 There's unexplained muscle pain or weakness, and the CK enzyme is raised to 10 times of the upper normal limit. Rhabdomyolysis is a very serious and a rare complication. 1 out of 100,000 patients per year, CK may be increased to the tune of 40 times. Myoglobinuria and acute renal failure occurs and is potentially life-threatening and may kill the patient. The other side effects are elevations of the transaminases, SGOT, SGPT, and diabetogenicity. Now, the European Atherosclerosis Society has introduced statin-associated muscle symptoms clinical index, that is SAMSCI, based on 4 parameters. The first parameter is regional distribution. Classically, statin intolerance affects the proximal muscle and is bilaterally symmetrical. So you can have involvement of the hip muscles or of the shoulder muscles. Classically, the symptoms occur in less than 4 weeks. And if you stop statin, that is de-challenge, symptoms usually improve in less than 2 weeks. And if you re-challenge the patient, symptoms will again appear in less than 4 weeks. So these are the classical symptoms of statin intolerance. If they are not classical, then statin intolerance becomes less likely, and this is the scoring system. So that if you have a score of 9 to 11, this is probable, 7 to 8 is possible, and less than 7 is unlikely. If you have a unilateral symptoms, non-specific distribution, which means the patient is not having symmetrical distribution, there are subjective symptoms, onset has been before statin initiation, or the onset is more than 12 weeks after statin initiation, then you must search for non-statin causes of muscle toxicity, which are outlined here. The pathogenesis of SAMES is multifaceted, and I'm not going to discuss the biochemical aspects. The second less common organ which may be affected by statins is the liver, but liver injury is very, very rare. As you can see, asymptomatic elevations in aminotransferases is only to the tune of 0.1 to 3.0%. This is dose dependent, class effect, and clinically not significant. When you stop statin, this usually reverses. Clinically significant acute liver failure, fulminant hepatic failure, autoimmune hepatitis, all are very rare complications. FDA recommends checking of liver function tests at baseline and later on only if clinically warranted. Otherwise, they are not to be repeatedly done. Diabetogenicity is another important complication of statin. You can see the hazard ratio is 1.13, which means a relative increase of 13% in statin-associated diabetes, and the absolute reduction is 0.3 to 0.5%. But what is important to remember is this diabetogenicity only occurs in individuals who are predisposed to diabetes, which means either they are obese, they have impaired fasting glucose, or TG is elevated and HDL is low. It is seen that one additional case of diabetes occurs if you treat 255 patients treated for statins for 4 years. Statin treatment prevents 5.4 vascular events in these 255 patients. So the benefit of statin treatment exceeds the risk. Therefore, diabetes is not a contraindication for statin therapy. So if a patient is diabetic, whether he is with ASCVD or without ASCVD, he should be offered statins because the benefit outweighs the risk. For primary prevention in low baseline CV risk, you can individualize your decision. There are several mechanisms by which diabetes is produced by statins. It decreases insulin secretion, it decreases insulin sensitivity, and there are multiple mechanisms. What is very important to remember is that diabetes is more common with potent statin. So if you are using high dose rosuvastatin or high dose atorvastatin, diabetes is more common. As you can see, diabetogenicity here, it is more compared to pravastatin, simvastatin, or fluvastatin. Now, these are the predisposing risk factors for statin intolerance. There are endogenous factors and exogenous factors. You can see age, above 80 years, female sex, low BMI, Asian ethnicity, pre-existing neuromuscular disorders, family history of myopathy, several renal disease, impaired hepatic disease, hypothyroidism, diabetes, and genetic polymorphism. If these are there, statin intolerance is more common. Then there are also modifiable exogenous factors, like if you use high-dose statin, excess of alcohol or grapefruit juice, illicit drugs like cocaine and amphetamines, heavy exercise, vitamin D deficiency is a very common cause, drug-to-drug interaction with gemfibrozil, protease inhibitors, amiodarone, CCBs, azole antifungals, macrolide, immunosuppressants, colchicine, and antipsychotics. So if we are faced with statin intolerance, how do you treat? You have to restructure statin therapy that we'll discuss. Then there are various non-statin drugs, as you can see on the slide, and there are some other options which we can try. If a patient develops statin intolerance, if the patient is on a lipophilic statin, please switch to a hydrophilic statin. If he is on a cytochrome 453A4 metabolized statin, switch it to a non-3A4 statin. And this shows, as you can see here in this slide, the hydrophilic and the lipophilic statins. If you look at the lipophilic statin, you have lovastatin, simvastatin, and atorvastatin. All these three statins are associated by high incidence of statin intolerance. But if you look at the hydrophilic statins, pravastatin, fluvastatin, rosuvastatin, or pitavastatin, they are hydrophilic and statin intolerance is less common. Likewise, if the statin is metabolized by CYP3A4, you can see lovastatin again, simvastatin again, and atorvastatin, then statin intolerance is more common. But if you use a statin which is not metabolized through this pathway, like fluvastatin or rosuvastatin or pitavastatin, statin intolerance will be less common. This is the PRIMO study which showed that statin intolerance is more common with atorva and simvastatin. If there is statin intolerance, try to use the minimum maximally tolerated dose, because statin has a lot of pleiotropic effects. So as far as possible, the patient should be on some statin. Do not try to totally remove the statin, so that you can use on an alternate day in very low dose, like rosuvastatin, even up to 2.5 milligram. You can use once a week, or you can use even twice a week. And what is very important to remember is that pitavastatin is a statin where statin intolerance is very rare. So if patient is not able to tolerate rosuvastatin or other statin, even at a low dose, you switch to pitavastatin. What are the non-statin alternatives? Ezetimibe, 10 milligram per day, it lowers LDL by 15 to 20%, well tolerated, can be used with statin or without statin. Bile acid sequestrants were used in past, no longer used, because now we have bempedoic acid. They also decrease LDL by 15%, and colcivelum has been used in 3.75 grams second per day, or 4 tablets of 6.25 milligrams. Both can be combined, ezetimibe plus bile acid sequestrant. But now the scenario is changed. If the patient has statin intolerance, you can use ezetimibe, or you can also use bempedoic acid 180 milligram, or both can be used. And when you use both these agents, LDL can be reduced by 35 to 40%. Pitavastatin 4 milligram, 2 to 4 milligram, ezetimibe, and Bempedoic is a very good, affordable triple combo for statin intolerance. If the LDL goals are very low, as in very high risk patient like polyvascular disease or familial hypercholesteremia, then you have to use PCSK9 monoclonal antibodies like evolocumab. Inclisiran is also a good alternative, but not yet available in India. It's available in UK. So a few words about bempedoic acid. Bempedoic acid is a new drug which is available in our country, 100 milligram, 80 milligram per day. Is tested in all these 4 trials. The clear outcome trial is ongoing. But in the context of statin intolerance, there are 2 trials, clear serenity and clear tranquility. How does bempedoic acid acts? Bempedoic acid is a prodrug and is converted into an active drug by enzyme ACVL1, which is very long chain acyl coenzyme synthetase, into this active drug, which is bempedoyl coenzyme A. This enzyme, which converts bempedoic acid prodrug into active drug, is not present in the skeletal muscles, and this is the reason why bempedoic acid does not produce muscle side effects. It acts in the liver by blocking the enzyme ACL, which is adenosine triphosphate citrate lyase, which inhibits the synthesis of cholesterol in the liver, which is ahead of statins pathway, which also inhibit synthesis of cholesterol. The drug is excreted through the urine by the OA2 channel, which is organic anion. And yes, you can see the uric acid and creatinine are also excreted to the same channel. And this is the reason that why on bempedoic acid, you can have some elevation of uric acid and creatinine. Now, these are the 2 trials, the clear serenity and the clear tranquility. The other 2 trials were conducted on maximally tolerated statin, but the subject today is statin intolerance. All these 4 trials have substantial number of diabetics, roughly 20 to 30%. So this also applies to diabetic patients. If you look at this trial, you can see both these trials, you can see clear tranquility. The LDL reduction is 23%, and here it is 23.6. Roughly, you can remember if you are using bempedoic acid along with statin, the reduction in LDL is 15%. If you are using without statin, it is 25%, as you can see. And if you are using statin plus bempedoic acid, it is roughly 35%. Bempedoic acid also decreases hsCRP, so it has an anti-inflammatory effect, which has beneficial effects. And this is a trial of combination. You can see again 39% reduction with both these drugs. And here you can see 36% reduction with both these drugs. What about side effects? The only important side effect is hyperuricemia, which is seen in small number of patients, and gout, a very small number of patients. This is not diabetogenic drug, rather it decreases blood glucose and is also to decrease weight. Tendon rupture is a rare but an important complication, and I have discussed. The other lipid parameters are also favorably affected. You can say non-HDL reduced by 13%, total cholesterol 11%, ApoB 12%. So while using bempedoic acid, you have to monitor uric acid if the patient is already suffering from gout, control his gout with uricosuric agent, and then initiate. Now, tendon rupture is a very serious but a very rare complication. And as you can see, this usually occurs in patients who are elderly, more than 60 years. They are taking steroids, chloroquinins, renal failure, and history of tendon rupture. And if there's slightest indication of joint pain, swelling, or joint inflammation, or pain at the site of tendon, the drug should be immediately stopped. The incidence is 0.3 per 100 per year, patient years. In the clear harmony and clear wisdom, which were on statin tolerated patient. But what is very interesting, that no tendon rupture reported in clear serenity or clear tranquility trials, and all tendon rupture occurred in patient with moderate or high statin dose, which means bempedoic acid may not be directly concerned with statin rupture. And if you are taking Simba 20 or Prava, you should avoid these statins. This is an example of tendon rupture. You can see the Achilles tendon rupture, the bicep tendon rupture, and this was the simvastatin and ezetimibe. So even statins and ezetimibe, they can also produce tendon rupture. The clear outcome trial is ongoing, and we are keenly awaiting the results on the cardiovascular event, but bempedoic acid has been already approved both in the United States, in the Europe, and in India. Now, PCSK9 are costly drugs, but they skew LDL to very low levels and are usually used in patients where the LDL target is very low, like polyvascular disease, recurrent coronary event. They are very well tolerated by statin intolerant patients. This is GAUS-2 trial, and as you can see, very well tolerated, and there's substantial reduction in LDL cholesterol. This is the OTC alternative trial with alirocumab, and again, you can see there's substantial reduction in the LDL, and they are very well tolerated in statin intolerance. This is GAUS-3 trials, and again, you can see the same picture. And this is an analysis of the GAUS-2 and OTC alternative. You can see 95 to 96% of patients who are statin intolerant tolerate drugs as well. Inclisiran is the other option, but it melts cholesterol from the vessel wall at a very big price. It inhibits synthesis of LDL, PCSK9 in the hepatocytes. And the beauty of inclisiran is that the compliance is very high because 300 milligram has to be given twice, 2 times in a year. So 300 milligram every 6 months. And this is data from the Orient 10 and 11, which showed that those patients who were statin intolerant, they tolerated statin very well with marked reduction in LDL. Then we have nutriceuticals, which have been tried, like red yeast rice. The active drug in red yeast rice is monocolins, which acts like statin, and therefore statin intolerance can occur with red yeast rice also. Coenzyme Q has been used, but statins have been shown to reduce plasma or serum levels of Q10, but statin treatment does not consistently reduce intramuscular coenzyme Q10. There are only limited data demonstrating reduction of myopathic pain with coenzyme Q, and most studies demonstrate no benefit with this. Coenzyme Q10 prophylactic or for treatment cannot be recommended at this time. It is used as an off-label, and you can see all these small trials have been negative. So its use is only as an off-label. Vitamin D does not produce statin intolerance, produces muscle aches and pains. So if a patient has vitamin D deficiency, this should be treated first. Rather, whenever we diagnose statin therapy, we first check vitamin D levels and thyroid hormones, because both these are common causes of muscle aches and pain. And if vitamin D is there, you should correct it and your muscle symptoms may be resolved. So in summary, how do we approach to a case of statin intolerance? If the patient is on a statin therapy, reports muscle symptoms which are likely to be statin-associated muscle symptoms, stop statin for 3 to 4 weeks. If there's resolution of symptoms, then this is statin intolerance. Restart statin with a different statin, very low dose. And if the symptoms are not likely because of statin-associated muscle symptoms, because there is no resolution of symptoms, search for another cause. Slowly increase the dose every 2 weeks to establish the highest tolerable dose. Check LDL level. If the LDL levels are not achieved, you have to utilize pitavastatin, combine it with ezetimibe if necessary, combine it with bempedoic acid. In very, very high risk cases, PCSK9 monoclonal antibodies has to be used. This is the latest Lipid Association of India 2022 algorithm, which means if you have a statin intolerance based on the symptoms, you assess the muscle injury. If the patient is having a tolerable symptoms, continue statin. If the CK is elevated less than 4 times, If the symptoms are intolerable, stop statin. If CK is 4 to 10 times, stop statins and intolerable. If CK is more than 10 times, this is a serious problem. But if there's no renal dysfunction, again stop statin. But if the CK is more than 10 times and renal dysfunction, then this could be rhabdomyolysis. Stop statin forever. Never use statin in this patient and consult a nephrologist and use non-statin therapy. Now, when you have stopped statin, reassess symptoms and CK every 2 weeks. If CK comes to normal and symptoms disappear after 2 weeks, then you can reinitiate statins with a very low dose, maybe daily, alternatives, bi-weekly or weekly. And if this does not succeed, you switch over to pitavastatin, initiate with 2 milligram, and if the patient tolerates to 4 milligram, if the goals are not achieved, you can use ezetimibe, you can use bempedoic acid. Both these drugs are very useful. And PCSK9 is only reserved for very high risk group, and so also inclisiran. So thank you very much for your kind attention.
Is there any diagnosis test available for diagnosis of statin intolerance?
The peculiar feature of statin intolerance is that there are no diagnostic biochemical tests or imaging modalities, or even biopsy does not confirm. So the diagnosis of statin intolerance has to be made only on the clinical grounds. That is the peculiar feature of statin intolerance.
Okay, sir, one more question. Is there any long-term RCT available for statin intolerance?
At the present state of time, there are no long-term RCTs available, but I'm sure in times to come they may be conducted. But this is a very difficult problem because you cannot ask any patient of statin intolerance not to have statins. Our attempt is to make the patient take statin, but this can be done in completely intolerant patients, which is less than 5%. Otherwise, partially statin intolerant patient, we cannot conduct an RCT because statin has to be given. They are mandatory. Only in this small number of patients you can have a RCT.
Okay, sir. Sir, one more question. Statin intolerance, which agent you will use first, emtricitabine or bempedoic acid?
There is no head-to-head comparison. You can use either agent. The advantage of ezetimibe is that the outcome data is available. With bempedoic acid, the outcome data is yet to be made available after the clear outcome trial becomes available. And you can combine. So you can use any, there's no hard and fast rule. But that is the advantage of ezetimibe.
Thank you, sir.
Hello, sir. Hello,
Yes.
sir. Hello, sir. My question
Yes.
my question is, sir, is bempedoic acid a diabetogenic?
Bempedoic acid, unlike statin, is not diabetogenic. On the other hand, it decreases diabetes and decreases blood glucose. So this does not have the effect of statins.
One other question, sir. Why the uric acid is elevated with use of bempedoic acid?
The reason is both bempedoic acid and uric acid are excreted through the same channel. That is the reason why uric acid may be elevated in patients with bempedoic acid therapy, but the incidence is much less. If the uric acid is already elevated, you must use drugs to decrease it. And if it gets elevated on therapy, you should concomitantly use drugs which decrease uric acid.
Thank you, sir.
Any other questions?
No,
another question in the chat box is statin safe in cirrhosis of liver? If there is active liver damage, then statins are not indicated. If there is no active liver damage and the longevity of life is more than a year or so, more than 1 year, because statin takes time to act, then they can be given. But active liver damage, statins are contraindicated. In cases of NAFLD, if the enzymes are elevated, usually the enzymes decrease, and when statin is continued. Active liver damage is a contraindication. Suppose you have very high SGOT, SGPT.
So nocive effect of statins.
nocebo effect of statin means that the patient has not been prescribed statins. And suppose you give one patient a placebo and another patient you give statins, and then ask him whether you develop muscle symptoms. The patient who is not on statin may also complain of muscle symptoms. So nocebo effect is this: patient is not prescribed a particular drug, but if you have told that do you develop muscle symptoms, they may develop. Just as some patients who are psychiatric, you give a pill that this will give you good sleep, they may sleep with that pill even when the pill is not hypnotic or a sleep pill. That is nocebo effect. The patient is not given the active drug, but the patient develops the side effects which are known with the particular drug, and which is not uncommon. Suppose you give statin, you ask the patient, please report if you have muscle symptoms. Some of them may report muscle symptoms even when they are not given statin. Suppose you have two groups of patients, one you are giving placebo and one the other you are giving statin. So those who are not given statin, they are on the placebo. If they complain of muscle symptoms, this is a nocebo effect.
What of the hypothyroidism? Hypothyroidism can also have the muscle symptoms, weakness and fatigue.
That's why whenever we diagnose statin intolerance, please make sure you have checked the vitamin D levels and the thyroid hormones. And if they are these deficiencies are present, you must correct it and then try to make the diagnosis. Both these are common causes and they may be mistaken for statin intolerance.